So welcome everyone. Thank you all so much for coming out tonight. I'm Dr. Bernard Ho, Vice Chair at Canadian Doctors for Medicare, and we're so thrilled to have all of you here with us for this important discussion and one that is central to the future of Medicare. And while we are meeting virtually tonight, the CDM office is located on the traditional territory of the Wendat, the Anishinaabe, the Haudenosaunee, Métis, and the Mississaugas of the Credit. Toronto is within the lands protected by the Dish with One Spoon agreement, and the dish represents the land that is to be shared peacefully, and the spoon represents the individuals living on and using the resources of the land in a spirit of mutual cooperation. The agreement captures our responsibility not only to the land, but to one another as well, which is why I think it's particularly relevant to the conversations we will be having tonight. I encourage everyone to reflect on the responsibilities and relationships of the place where we are joining from. At CDM, we recognize the disproportionate and unjust disparities that Indigenous peoples continue to face today due to the racism and the ongoing effects of colonialism. And we are committed to working to reduce these inequities as part of our work to advocate for better Medicare. Please feel free to add in the chat your name, where you're coming from today, and why this matters to you. Before we begin, a few housekeeping matters. This meeting is being recorded so that it can be shared with others who couldn't join us tonight. Please feel free to send chat messages in the chat box to the attendees. Since we're using the meeting format for this discussion, we kindly request that you keep your mic on mute and put your questions in the chat box. And closed captioning is available and can be turned on. And now to the topic at hand. So with over 6.5 million Canadians without a family doctor, virtual care and nurse practitioner clinics have become valuable additions to primary care services. But because the 40-year-old Canada Health Act does not explicitly address virtual care or nurse practitioner care, for-profit healthcare providers and private insurance companies are exploiting this gap and billing Canadians to pay out of pocket for medically necessary services. With provincial and territorial governments choosing to be unresponsive, this situation risks further descent into a two-tiered healthcare system. Now, charging for medically necessary healthcare, whether by billing patients out of pocket or through their employer-funded private insurance, contravenes the spirit and intent of the Canada Health Act. In the next hour, we will explain how this situation is harming patients, stressing our public healthcare system, and weakening Medicare, all while ignoring better solutions than the status quo that only benefits for-profit virtual care and private insurance companies. I'd like to introduce our first speaker. Dr. Danielle Raza is a family physician with Unity Health Toronto's St. Michael's Hospital and assistant professor with the University of Toronto's Department of Family and Community Medicine. He is a past chair of Canadian Doctors for Medicare and founding physician lead of Unity Health's Sumac Creek Health Centre in Toronto's Regent Park. And I'll give it to Dan.
Thank you for the intro, Bernard, and thanks everyone for joining us. I'm going to walk us through a few things tonight, and I'm going to do that. I'm going to lean on some slides. I don't usually do that when we do these webinars, but I'm going to share some slides with everyone tonight. Can I just get a thumbs up from folks, or let me know that you can see the slides? Okay, perfect. So Bernard mentioned the challenges we're seeing with the rise of for-profit virtual care companies, as well as patients being billed out of pocket for in-person services. And these, of course, are not occurring within isolation. They're occurring in the broader context of the crisis in primary care. So we don't want to talk about these issues in isolation. We want to see them in this larger challenge our health system is facing. So I'm going to talk a bit about primary care, what exactly we mean when we use this term, answer these three questions: what primary care is, what isn't primary care, and then the reason why we're on tonight, what we can do. And that's going to set Karen up to talk a bit more the specifics about this interpretation letter that many of you may have heard about in the news, or may be the reason why you signed up for tonight. But first, I'm going to just lay the groundwork, talk about what primary care is. This looks at three kind of concepts or models of first contact care. And what I do and the other folks here who are family doctors do is we sit in that gray circle. We practice family medicine. It's about the clinical relationship that we have, often spanning decades, between our roster of patients, and ourselves. But of course, family medicine isn't the only component of primary care. Primary care is really team-based care. It's care delivered not just by family doctors, but it could extend to nurses, community health workers, social workers, all other types of healthcare providers. But really critically, we've come to define primary care in the literature through these four C's, and many of you may already be familiar with it. It's care that is first contact, continuous, comprehensive, and coordinated. And it's important that all four C's, right, are present in order for us to have primary care. Walk-in clinics, emergency departments, they all have a place, and they're all first contact, but they don't provide continuity or continuous care. They're not necessarily comprehensive or coordinated. So really, it's the presence of all four C's that define primary care. And then there's this broader concept, primary health care, that isn't just about the clinical relationships between patients and teams, but it's about this broader concept and partnership between primary care, public health, population health, social policies, and social determinants of health. And while primary health care sounds very similar to primary care, what we're talking about tonight is really that primary care piece, that clinical relationship between patients or communities of patients and teams. So that's what primary care is. This is a great paper in Canadian Family Physician if folks want to dig in a bit more into where this definition comes from. And this puts it in context. This is just the number of visits, the tallies in terms of daily healthcare utilization in Ontario, and it's just here to, I think, illustrate an idea or a concept that many of us already kind of understand in our bones. GP visits is a proxy for primary care. And, we spend a lot of time with good reason, including at CDM, talking about how we need to improve elective weights for hip and knee surgeries, ways we need to improve weights for diagnostic imaging. And when you look at the overall volume of healthcare visits, the reality is though these are areas that we need to improve and we need to continue to do good work here, most of the way that people in Canada encounter the healthcare system is this first contact continuous care that occurs in primary care, or frankly, doesn't occur. And the reason why the crisis is reaching a boiling point is because this most common occurrence or interaction with the healthcare system, it's just happening less and less. We all have stories of family, of friends who either don't have a family doctor or NP, or even if they do, are struggling to get in to see them because the practices that do exist are just so overwhelmed. And this is all, of course, important because when you look at the evidence of high-functioning healthcare systems, in particular high-functioning universal healthcare systems, primary care is at the cornerstone. Many folks will have heard the name Barbara Starfield. She was or is the most eminent health services researcher who published the seminal paper back in 2005 that looked at evidence from across the world and didn't just answer the question, is primary care important or not within broader health system, but what makes it so critical to high functioning healthcare systems. And she broke it down to these 6 factors. Number 1, increased access, and this is really critical, increased access to health services for communities that have traditionally been marginalized. And of course, this is not just access to primary care, which is the front door to our healthcare system, but it improves access to the rest of the healthcare system for these communities. Because primary care is built on relationships between a primary care provider and the team and patients, it can deliver equivalent and in often cases better care than specialty care. And it's not because as clinicians, family docs are any more skilled or competent than our very talented specialty colleagues. It's really the secret sauce of relationships and knowing your patient and just having the benefit of years and years of their care and being able to tailor treatment and testing accordingly. And then, of course, greater focus on prevention, early management of health problems, and happily, the reduction of unnecessary or costly care, which, in my view, is never a reason. It shouldn't be the fundamental reason we choose to do things. We shouldn't choose to do things because they cost less. We should choose to do things because they're the right thing to do and they make people healthier. But it's always a good thing when they're all also cost effective. So that's a little bit about what primary care is, but it's also important for us to talk about what primary care isn't. And the reason why it's worth spending a few minutes on this as well is because a lot of first contact care, especially the more controversial type of first contact care that I'm going to highlight that we're not used to seeing in the Canadian context, is being described as primary care when in fact that's not what it is. The first is virtual only walk-in care, and I think many of us have interacted with this either personally or read about it in the news through one of these new for-profit virtual walk-in clinics that really have accelerated in terms of their footprint as a result of the pandemic. We read about how many services which patients might reasonably expect to be covered by Medicare patients are now being paid, asked to be paid out of pocket, and that's what this interpretation letter is supposed to solve. Karen's going to talk in more detail about that. But it's also worth pointing out that if we rely on virtual only walk-in clinics to solve the primary care crisis, it's also low value care, right? This was a really great study that was published about a year ago in the Journal of Internal Medicine, and it was put out by researchers based in Toronto at U of T. And it found that the folks who were accessing virtual only walk-in care were healthier and typically had less healthcare utilization, which is which, if we're interested in increasing access to folks who are most marginalized, in keeping with the evidence that Barbara Starfield found around primary care, that uh, that doesn't fit that pattern of primary care. You're more likely to require repeat visits. You're less likely to have a subsequent in-person visit with the same physician, so you don't get that same continuous care that's part of the 4 Cs of primary care. And you're twice as likely to have an emergency department visit because you're depending on this episodic care that doesn't have the option for an in-person visit. And so then, of course, you're asked to go to the emergency department. Now, I don't think anyone wants to access care this way. The reason that these services exist is because people are desperate, right? They can't get in to see a family doctor. They don't want to have long waits in the emergency departments. So for some folks, this is just the options that they're left with. And I don't think we can fault people for trying to seek care when they can, but we have to be really careful and deliberate about the choices we make to improve access for folks and whether we want it to be a model that entrenches these for-profit virtual care models or if we want to build something better. And the second piece of what primary care isn't is the rise of both executive health clinics, but also private pay nurse practitioner clinics. The second piece has been in the news a lot more recently. There was a very well publicized case in Ottawa, but that's not the only community where new clinics have popped up, being run that have been staffed mainly by NPs and where patients are being charged either on a piecemeal basis or an annual or monthly membership fee. And of course, this violates one of the fundamental principles of Medicare, and that's determining access based on ability to pay. Again, not something that we see in high-functioning healthcare systems where primary care is supposed to expand access to marginalized communities. And of course, it leads to a regressive distribution of healthcare workers. I think everyone on the call tonight knows and appreciates we have a healthcare workforce shortage. We're seeing a burnout, especially in family medicine. We're not recruiting enough medical students to go into family medicine residency, and we don't have enough family medicine residents practicing comprehensive family medicine. So when you take some of those folks and you put them behind paywalls, and you privilege access to people who have the ability to pay, again, that's not an equity first primary care principle. We see it's not a way that we build high functioning healthcare systems. And then, of course, as soon as you turn healthcare into a consumer good, you fall prey to the paradigm that more is better, and oftentimes, and this I will say is anecdotal. We don't really have good data on this, in part because many of these for-profit clinics don't like to share a lot of the data that we rely on for health system evaluation. But I will say anecdotally, my colleagues and I have noticed many folks who are treated in executive health clinics are subject to over and unnecessary testing. Now, the thing that these executive health clinics and these private pay NP clinics have in common is that they both ask patients to pay fees to access care that would otherwise and reasonably be expected to be covered under Medicare. But the thing that makes them different is the way that they get around the rules. Executive health clinics typically ask patients to pay these, annual fees, which can range in the thousands of dollars. And they publicly say that these fees are to cover uninsured services, things like dietitian classes or physiotherapy services, and that they're not to cover the doctor's time with you. But when journalists and other activists have essentially done these secret shopper investigations where they've called the executive health clinics and asked to see the physician for a covered service without paying the membership fee, they're essentially told this clinic isn't for you. Go see a public doctor. And this is a situation that unfortunately has existed for a number of years. You can see that there's a screenshot from an article that reported on these secret shopper investigations from as early as 2017. The situation we're seeing with NPs is much newer, and that is part of the reason why we need an interpretation letter. Nurse practitioners have a scope of practice that overlaps with family doctors, but because of the way we define comprehensiveness in the Canada Health Act, NPs in the current interpretation of the CHA are not covered or deemed insured, and that's one of the reasons why we have these murky rules that are giving rise to these NP private clinics. Okay, so all of this begs the question, if we know what primary care is, and we know what primary care isn't, what can we do about it? I like to break it down really simply into two things. We need to do more of the good things, some of the good things that we're actually already doing. So do more good, but we also need to do less bad, and I've highlighted some of that as well. So I'm going to start with the more good. What can we do that we're already doing, or what are some new ideas that we can start to think about and start to implement to improve access to primary care? Well, the first is team-based care. This is from a lit review that's a few years old now, and the literature happily has not changed. And it showed that when you compare team-based care to care that's delivered in a solo practice model, essentially across everything you can measure, whether it's access to care, satisfaction of not just patients, but the people who work in these models, acute care use, quality of care, cost savings, team-based care performs better and consistently, not just in jurisdictions across Canada, but across the world. And I think, this makes sense for many of us who, not just work in the system, but who have seen how things have changed really since the inception of Medicare. If I had entered practice as a family doctor 20, 30 years ago, I could hang up my shingle, open my practice with my nurse, and probably do pretty decent, probably deliver pretty high quality care. But there's no way that I can competently manage the much more complex space and chronic disease in 2024 as a solo practitioner the way that I might have been able to do 20 or 30 years ago. Team-based care now really is the standard of care, but not everyone has access to a family doctor, NP, and even folks who do, not all of those types of healthcare workers work as part of a team, and we need more of those sorts of teams. The other thing we need to do is not just have team-based care, but also think about the way that we distribute it. So this is a map of the area in Toronto that I live in. It's the Toronto District School Board catchment area that my kids fall into. And this school board metaphor is being talked more and more about a way for us to plan primary care. And frankly, it's an idea that a few years ago was totally radical, but now is becoming more and more mainstream. And I think for a couple of reasons. If there's other people here who have ever tried to enroll their kids in daycare or had people in their family who have, they can probably we probably have a lot to talk about. I remember with my two girls, as soon as my wife had finished, was out of her first trimester, I got on the phone. I called every single daycare in our neighborhood to make sure that we were on the wait list, so that when our daughters were 12 months old, we would hopefully have a spot. That took an incredible amount of work, incredible amount of patience, and we had to cross every finger and toe to make sure that we had that spot, and luckily we did. But when our girls were ready for kindergarten, I went online, I made sure I spelt their names correctly, and I hadn't forgotten their date of birth, and I hit submit, and I was guaranteed a spot in the school that was just down the street from where we live. Why can't we think about organizing primary care the same way that we organize school boards? Not only that, when teachers graduate Teachers College, we don't ask them to find 10 of their friends to set up a school and then tell them, we're going to pay you for the school that you need to set up based on every student that you teach. Right? Yet that's exactly how we ask new grads who are finishing their residency in family medicine to practice. So this school board style of primary care is one that's being talked about more and more. There have been some high-profile appointments, including of Dr. Jane Philpott in Ontario to help advance this model. But Dr. Philpott's not the only one who's talking about this. We have champions for this across the country. So this is something that we need to start to do more of. And finally, we need to also make sure that our primary care system reflects the wants and the desires of people in Canada. There was this incredible study that was done, not even a study actually, it was an exercise in deliberative democracy done by a colleague of mine, Dr. Tara Kiran, where she worked with with one of the organizations that was also involved in the citizen panels that went through these deliberative processes around electoral reform. And they went across the country to every single province and territory. They had representative folks from communities come together, dedicate, not just, an hour with a focus group, but dedicate weekends of time to hear experts talk about primary care, talk about different ways we could reform the system, and then engage in dialogue with each other to come up with what were some of the standards or the principles that they wanted as core parts of their primary care. And they came up with these 6 standards. One, primary care clinicians who work with other teams in a publicly funded team, care that they could access, care that was connected to community and social supports, that also supported mental and social well-being. They wanted care that was also accessible online, including accessing their records online, care that was culturally safe and appropriate, and that also was from teams that reflected the communities that they were serving, and that was also accountable to the communities that they served. And the other piece of good news is that none of this is reinventing the wheel. It's all actually being done before, in particular in other jurisdictions that have that are part of this, quite exclusive club that I hope becomes less exclusive and that we can join in the not too distant future. It's this 95% plus club where 95% of people who live in these four countries are attached to a primary care provider: Finland, Norway, the Netherlands, and the UK. Now, of course, they all do it differently. No healthcare system is perfect, but the things that these four countries have in common is this school board style of attachment, where someone is automatically registered with a group in their neighborhood, where the teams that work together are bound in this social contract that also involves stronger formal agreements and including accountability agreements. They're teams with excellent digital tools and IT systems. And this last one really blew my mind, but in many of these places, walk-in clinics essentially don't exist. And that's because these neighborhood teams, as part of the care that they deliver, also offer robust evening and weekend clinics that essentially obviate the need for walk-in clinics. Um, this slide, I think, is also really powerful because it shows that we have an incredible opportunity to actually bring the spending for primary care in Canada up to the level of many of our peers. Because so many of the services that are fundamental to delivering high quality primary care fall outside of Medicare, right? We know Medicare is really only universal for two things, for doctors and for hospitals. And of course, primary care is more than just family doctors out in the community. Um, because our universal basket of services really only includes that, it also means that primary care services are underfunded compared to many of our international peers. And of course, it really depends on what jurisdiction you live in, whether or not you have access to a wider basket of these services. And even if you live in a jurisdiction, for example, in Ontario, only 20% of people in Ontario have access to team-based care. So there's room for us to bump up our spending to support this style of care. And the other thing we need to do, in addition to doing more good, is we need to do less bad. We need to cut down on some of the bad things that we would argue are actually harming access to primary care. The first has to do with private insurance. Now, I'm not going to make the argument that a private insurance in and of itself is a bad thing. But I think one thing we do need to recognize is services that we have traditionally expected to be funded by Medicare now are starting to fall under funding of private insurance, in particular private insurance that is linked to employers and employment. I'm in particular talking about the rise of, virtual care walk-in services, where employers are not just covering prescription drugs, for example, or physiotherapy, but now are offering this as a workplace benefit. And not just employers. I commute around the city in many ways. I'm a cyclist, but I'm also a driver, and I'm a member of the CAA. And there's one particular service that the CA also is covering as a benefit of membership that I apparently have access through because I'm a member. And many of these private insurance companies will argue that this is actually a service that's a pressure relief valve, right? It's allowing people access to care that they may not otherwise be able to access, and it's taking the pressure off of publicly funded services, for example, emergency departments. But we know that's not true for a couple of reasons. One, because we of course already have, as was mentioned, a shortage of healthcare workers, and we're taking a limited supply and we're locking these people behind not just paywalls, but now work walls when these services begin to be associated with workplace benefits. But I think the other thing that people don't really appreciate is that whether or not you have access to a job-linked private insurance plan, you're still paying for it. The federal government subsidizes work-linked private insurance plans to the tune of $4 billion a year, and that's been rapidly increasing. So this is data from Finance Canada, and you can see that not that long ago, in 2018, we were subsidizing these plans $3 billion a year. This year, the federal government is projecting upwards of $4 billion of subsidization. And this is just federally. All provinces except Quebec offer further subsidies. So this is care that all of us are paying for, even though many of us can't even access it. And of course, the cruel irony is if you're one of the lucky ones that doesn't just have a good, stable job that's not precarious, but a good, stable job with decent benefits, you're also probably generally healthier, higher income, and actually less in need of intensive healthcare services. So it's a very regressive way to design access to first contact care. And in fact, if you take those $4 billion, I think many of us could think of other more progressive ways to enhance access to first contact and continuous care. And the second thing we need to be doing less bad of has to do with implementing this interpretation letter that many folks may have read about, and that I'm not going to spend too much time on, but I'm going to hand over to my colleague Karen Palmer to speak briefly of briefly too. And the last thing I'm going to say is tonight is really focused on this interpretation letter about something we can do uh, tonight, tomorrow, something we can talk to our friends and neighbors about this week. But in the new year, you're going to be hearing more from us at CDM and our allies about how we're going to do more good to build a primary care system that works for everyone.
Perfect. Thank you so much, Dan, for laying out such a complex issue and for giving us a vision of what good primary care can look like in the country. We're going to take a brief pause here just for any questions from the audience. So if you do have any questions, feel free to put them in the chat and we can create a speakers list. We did have one question sent in advance in the meantime while people type their questions in, and perhaps I'll flip this one over to Dan. So the question is, if primary care is reorganized into a team model, which services will be excluded from OHIP under the existing terms of reference for OHIP?
Yeah, it's a good question, and I think, the answer to this is we already know. We're not going to reinvent the wheel for team-based care. Across the country, we already have community health centers, which are one particular way to deliver this type of care. As many folks will know, the physicians and others that work, they tend to be salaried, so it's not really based on a fee schedule. They're lower volume because they also deal with patients that are more complex from both a social and medical standpoint that require more time, require translators, etc. But even for other sorts of communities, for example, in Ontario, we have capitated family health teams. And that incorporates the existing schedule of benefits. So OHIP in Ontario and ties accountability agreements for delivering after hours and weekend care to funding for interdisciplinary team members like social workers or pharmacists. So we actually already have a model that exists, and in jurisdictions where that's in place, I would argue that we actually need to expand those sorts of models, and then of course find ways to improve them based on past experiences. BC recently has expanded funding for a similar type of team-based care. So we're not reinventing the wheel here. We're expanding what we already have, or we're iterating on and tweaking the funding models to build something better and to expand on a base that's already there.
Great. We have two questions in the chat. So first one from Fiona. Do you think that Canadian doctors in primary care in particular would be willing to become salaried? Is the first.
Yeah, a great question. And I think this really falls along generational lines. I practice in a community setting, but also in an academic practice where we are training family medicine residents. And I can say from both my firsthand experience, but also of many of my colleagues, that new grads are not interested in being small business owners. They don't want to get into practice and be responsible for HR and payroll. They value much more work-life balance than family doctors from another generation. Which is not to say that those of our senior colleagues don't value work-life balance, but that was never really an option for them. And I think one of the reasons it's an option for us, I would describe myself as mid-career, is because as medicine has been feminized, it's also with good reason. A lot of the male physicians like myself have also benefited from this greater emphasis on work-life balance. 15 years ago, I would have never been able to access parental leave, but now I can, even though I'm not the birthing parent. And so this greater emphasis on work-life balance, on not wanting to have to deal with, payroll or learning to be an accountant, wanting to focus on medicine, and medicine that's increasingly complex, that leaves less headspace to worry about having good relationship with your landlord, means that I think people are increasingly open to the idea of salary, and willing to give up some measure of independence in order to have that security and that work-life balance.
Thanks, Dan. Next question from Eric. What do you think of Jane Philpott's idea of a Canada Primary Care Act and Norway's Patients' Rights Act?
I'm not familiar with the with that legislation in Norway, so I can't comment on that. But I think Dr. Philpott's idea of a Canada Primary Care Act is a very good one. Um, there's there's been different approaches that folks have had to expanding the services covered by Medicare. So not just primary care, but for example, pharmacare. And so, before we had the passage of the most recent pharmacare bill for diabetes and contraception, there was debate: do we reopen the Canada Health Act to include prescription drugs, or do we introduce parallel legislation? And so there's a similar sort of debate happening right now, I think, in terms of the legislative framework for primary care. Dr. Philpott's proposed a brand new Primary Care Act. Others want to reopen the Canada Health Act. I have my opinions on which way to go, but I think at the end of the day, um, I'm frankly agnostic in terms of what's the best legislative pathway. Um, uh, and I'm open to a parallel act, or if folks can convince me it's safe to open the Canada Health Act to do this as well, then, I could be persuaded that way too.
Okay, and one more question from Anne before we move on to Karen. So Anne says that she was on a Zoom with CFMS. They had the head of the College of Physicians and Surgeons in Nova Scotia, who said that there are about 33,000 missing primary care physicians, but we're only graduating 1,300 a year. And what do you make of this shortage argument of family physicians that we're graduating?
I buy it. I definitely buy it, but I don't think it's the total answer. Um, we don't have enough medical students choosing family medicine, and we don't have enough family medicine residents choosing to practice in comprehensive family medicine. That's for many reasons. One of the reasons is we haven't created uh, enough opportunities for new grads to practice in teams, but we're training them in those teams. So, of course, if you're new to practice and you don't see something that's familiar for you to work in, you're going to look for other models of care to practice in. But I think part of it is not continuing to do what we've already done. I am one of the lucky doctors that gets to work as part of a team, and I know that because I work in a team, I can care for many more patients as part of my roster than I could have on my own. But again, in my province, only 20% of people have access to a team like that. If 100% of people did it, or if 100% of family doctors practice in teams like that, then we could expand the capacity of the family doctors that are already out there practicing comprehensive family medicine. So I think it's true that we have a shortage. We need more physicians practicing in family medicine, but we also need to change the way that we deliver primary care so that each family doctor can take care of more folks. And of course, there's a role for nurse practitioners as well, to practice primary care and get more people attached to.
Perfect. Thanks, Dan. Feel free to continue to write questions into the chat. We're going to collect all of them at the end, and if we can't get to them, then we'll address them by email. I'm going to move on to our second speaker now. So Karen Palmer is a health policy and health services analyst, researcher, and consultant. Her work focuses on comparative international healthcare systems and health system reform. She holds adjunct professor appointments in the Faculty of Health Sciences at Simon Fraser University and the Department of Family and Community Medicine at U of T. And I'll hand it over to Karen.
Thanks, Bernard. So Dan has outlined CDM's concerns about providers, whether those are physicians or nurse practitioners who bill either patients or employer-funded private health insurance companies for the services they provide that are covered under the Canada Health Act and would otherwise be funded by our provincial health insurance plans. And this can include physicians who provide virtual care, such as when they work for virtual care companies that provide episodic virtual only services. And it can also include nurse practitioners wherever they work and provide these types of services that would otherwise be insured. And it includes primary care services, or at least a version of primary care that is often not consistent with the 4Cs that Dan described. But it goes beyond primary care, and it also includes specialist consultation services that are provided in these ways. And charging for these services contravenes the spirit of the Canada Health Act. Most concerning, I think, is that the longer this behavior goes on, the more it becomes normalized, and the closer it moves us towards a multi-payer system where patients are billed for these services at whatever rate the market will bear. And so how do we hurry up and fix this? Well, beyond the work of modernizing and improving access to primary care in the ways that Dan outlined, here's the quickest way to stop private pay for medically necessary services. On March 9th, 2023, the Federal Minister of Health issued a letter to the ministers of the provinces and territories on the importance of upholding the Canada Health Act. And in that letter, he wrote that he was, and I'll quote, very concerned about the recent increase in reports of patient charges for medically necessary services, and that it was his intent, and I'll quote again, to clarify in a separate Canada Health Act interpretation letter that no matter where in the country Canadians live or how they receive medically necessary care, they must be able to access these services without having to pay out of pocket. So, and that is so that as our system evolves, it remains true to the spirit and intent of the Canada Health Act. So what's an interpretation letter? Well, it's a letter to the provincial and territorial ministers clarifying the federal position on the Canada Health Act. In the 40 years since 1984, when the Canada Health Act was enacted, there have only been 3 other policy interpretation letters. They are used very sparingly. So the first interpretation letter was sent in 1985 from then Minister Jake Epp, and it clarified the federal government's expectations regarding the application of this new Canada Health Act, new at the time. And its purpose was to ensure that provinces and territories adhered to the Act's principles in delivering healthcare services. The second letter was sent a decade later in 1995 from then Minister Diane Marleau, and it expressed concerns about the proliferation of private, meaning for-profit, clinics in general, and clarified that private clinics were that provide acute and rehabilitative or chronic care can't charge facility fees for medically necessary services because it contravenes the principle of accessibility in the Canada Health Act. And it called on ministers to introduce regulatory frameworks to govern the operation of private clinics, and it made clear that the federal government would deduct from the transfer payments any amounts charged for facility fees in respect of medically necessary services. And the third interpretation letter, the last one until the one that we hope will soon be issued, came in 2018 from then Minister Jeanette Petitpas-Taylor, and it deals with 3 initiatives. It created the Diagnostic Services Policy, which says that facilities can't bill patients for medically necessary diagnostic services, and that any charges to patients for these services will be considered to be in contravention of the Canada Health Act. An example of this is that in British Columbia, where I live, we are currently not in compliance with this policy because we are still waiting for the provincial government to enact what's called Section 18.1 of the Medicare Protection Act, which pertains to diagnostic services. And so accordingly, the federal government has deducted $17 million plus from BC's transfer payments. It also created what's called the reimbursement policy, which says that provinces and territories are eligible to be reimbursed for deductions taken in respect of patient charges, should they demonstrate that they have taken action to remove these barriers to access. And lastly, that third letter strengthened and standardized reporting from provinces and territories to Health Canada and from Health Canada to Canadians. So these interpretation letters essentially provide guidance to the provinces and territories on how to align their healthcare policies. They clarify ambiguities by providing an official interpretation of the Canada Health Act's provisions and the federal government's expectations. They help to enforce health system integrity, and they aid in conflict resolution should disputes, when disputes arise about provincial or territorial policies. So while they don't have the force, these interpretation letters of law, they do set precedents for decision making. And in essence, they play a crucial role in reinforcing the federal government's role in upholding the values of the Canada Health Act and ensuring that the principles are consistently applied across the country. So since March 2023, when that when the then federal minister said they were about to send out another interpretation letter, issue another interpretation letter, that's nearly 2 years ago. And the Office of the Federal Minister of Health has been working toward issuing this fourth policy interpretation letter. It's seen by many as an easy win, yet the decision on when, and I fear whether, to finally issue this letter depends on Cabinet and the Prime Minister's office, mainly. And so in this really supercharged political environment, they continue to delay it. And I think that if this doesn't happen before an election is called and were this government to fall, the letter would be in jeopardy. So Canadian Doctors Medicare has tried to encourage the release of this letter. We've published op-eds, we've talked about it in the media, we've spoken to those who we know have influence. But we can do more together by calling on this government to issue this letter, hopefully before Christmas. We have everything to gain and nothing to lose by trying. So in my view, it's the most important thing this government can do right now to protect our healthcare system and ensure that all of us continue to have access to care based on our need, rather than on whether we choose to pay or whether we have a job with benefits that covers virtual care and nurse practitioners. So I'll stop there and I'll turn it back to Bernard to tell you how we can hopefully influence our government to keep their promise.
Perfect. Thanks so much, Karen. So on that note, in the last 10 minutes here, I'm hoping everyone can join us in a call to action. We're going to call the Minister of Health's office and the Prime Minister's office and leave voicemails for them to urge them to release the interpretation letter that's been promised since March of 2023. So we're going to screen share a script on the screen and also share it in the chat. Please remember to leave your mics on mute for this. After you call, we're also going to put a spreadsheet in the chat. If you could please put your name and email in that spreadsheet, and we'll be in contact with you afterwards. While we do this, if you have any questions for Karen or for Dan, please feel free to put them into the chat as well, and I'll continue to moderate the chat too. So Zarif's just going to put the script in the chat now, and we're going to screen share it as well. And if you don't know your riding, at the bottom of the script, there is a link to contact your local MP. You can put your postal code in that link there, and it will tell you what your riding is. Perfect. So if we could all just take the next 2 minutes. Yep, that's if you want to share the script with others, that's also perfectly okay, and I would highly recommend that too. So if we could just take 2 minutes to call and leave a voicemail.
Excuse me, I just have to ask, are we phoning the number of in the federal, in the parliament, or are we phoning their office in their riding, or both?
So we can phone, so you can phone your local MP, whoever your minister.
Yes, I understand that, but they have two phone numbers. One is Ottawa, one is like Corner Brook.
I think either would work.
Okay.
It would.
All right, that's
either.
fine. I just wanted to make sure.
Yeah, so we'll just take 2 minutes just to call them right now.
Now it's going.
I wasn't able to leave a message. It wouldn't let me leave a message with Trudeau's phone number. Okay, I don't know if you can hear me.
Hey, because people are talking probably on the phone, just waiting to respond. But for Trudeau, maybe we could leave an email, just because they might have turned off their voicemail for tonight. Just strange. And then for Holland, we can leave a voicemail.
In the last couple of minutes, Zarif is going to share the link to the spreadsheet in the chat. Again, if you are able to call either the Minister of Health or your local MP, please leave your name and email in that spreadsheet, and we will contact you further. As Dan mentioned, the Prime Minister's voicemail has been deactivated. He probably got wind of our phones app and unfortunately knew that this was coming. So you can also leave him a message that Dan linked in the chat too. And as Brian also mentioned, you can email your MP or email the PMO or the Minister of Health with the letter that we had today, and we can share that letter as well. Any final questions for our two panelists tonight?
Yeah, I guess I've got so many questions. Um, the CDM link has sort of the CDM website should have the center of all this information, and I could re-examine things there, copy them, that kind of thing. Okay, so
So,
the CDM website afterwards then is where I'll spend some time. Thank you.
so what we can do also afterwards is share the link to the script and to the spreadsheet to everyone here. If you want to share with your colleagues, if you want to email your MP, or if you want to email the Minister of Health and the PMO, please feel free to do that.
Yeah. Because this machine is not what I'm used to. The response in my cursor is just not there.
That's okay. Yeah, that's no problem. If you're able to do it at a later time, that would also be great.
Yeah. Okay. Well, we'll try that. Thank you.
But I think downloading that phone script is what everybody needs. So send that out again.
Okay. So, hi, I put my name into the spreadsheet, the interpretation letter phones app, but I don't know how to save it.
Saves automatically.
Oh, it saves automatically? Okay, good.
Yeah, it's a Google spreadsheet, so anything you put in will save automatically. So
Oh.
you don't have to worry about that. I see that Carol had a question in the chat. Is there any restrictions on providers to prevent selection of patients by age, health condition, et cetera? I guess in the context of neighborhood family physicians.
Yeah, Carol, it's a good question. So it depends on how the models are designed. So existing team-based care in Ontario, for example, community health centers have particular catchments, and so they focus on folks in their particular neighborhood, but other teams like family health teams don't necessarily have catchments. But the idea, if we move towards the school board style, is that you would have, the right to register to the clinic that's closest to you. But especially when a model like this is instituted, I don't think anyone wants to disrupt these pre-existing relationships, even if you've already had a team for many years, but maybe that's not necessarily close to you, but you have a pre-existing relationship. So I think the idea is not to disrupt pre-existing relationships, but as we begin to attach people to primary care, do so in this way where we're prioritizing access that's close to home. Yeah, and Carol, it's a model that so community health centers exist across the country, and there is a form of also team-based care in Alberta. It's not exactly the same way, but there is a model there. And so again, the idea is as people are being attached, we focus on doing it on a neighborhood by neighborhood visit and not disrupt people's existing relationships.
Thanks, Dan. If there are any final questions, feel free to put them in the chat, or you can email them to us directly. As I mentioned, we'll collect all the questions we couldn't answer tonight and answer them via email in the short future. So just in closing, I want to thank everyone here for joining us tonight and for such an engaging conversation. I want to thank our panelists, not just for your participation in tonight's webinar, but also for the work you do to help us understand these complex and important issues. And as we mentioned earlier, if you are a medical student, resident, or practicing or retired physician on the line and not yet a CDM member, please consider joining us today. For anyone else on the line, please consider signing up for our newsletter for future updates and invitations to events like these. There's definitely strength in numbers, and it's only by coming together that we can bring about real change. And we know that we have a lot of passionate and knowledgeable guests in this audience, and we look forward to working with you to strengthen and improve our public healthcare system. And fingers crossed that we get this interpretation letter before the holidays. So thank you again, everyone, and hope you have a wonderful night.
Thanks to everyone. Just on the question Raymond asked on the chat, we will make sure for everyone that attended this call, you have access to the spreadsheet and all the documents that was shared right afterwards, or at least maybe by tomorrow morning. And the link to the spreadsheet will be open. If people are having any difficulties with any of the documents or the spreadsheet, feel free to also ask me. I can stay back 5 or 10 minutes to help anyone, and our panelists can definitely feel free. I know they have a lot of family commitments to take off.
Thank you.
Thank you, everyone. Eric, I saw your question in the chat as well. I just replied with a link to our website with an explanation of the interpretation letter that goes through what's expected and what we're asking for.
Thanks.